Thank you. Thank you very much for your introductions. I'm going to talk about the possibility to really assess the fluid status that, as you heard from the previous speaker, is very important in order to start adequate treatment. These are my disclosures. It is very clear that in many acute disease, if you are going to give too much fluid or too less fluid, you are going to deal with mortality. From this paper from Jean-Louis Vincent, in septic patients where you are going to give so many fluids, you can have an increase in mortality if you give too much fluid. So it is really important dealing with acute disease to understand the value of fluid status in order to appropriate treatment. And this is what I'm going to try to address. Of course, first of all, you need to understand that many acute diseases are linked both with less fluid into the body or higher level of fluid in the body, such as congestion. You should really know to exactly understand in the acute phase which disease is linked with the disease to typical situation. I will try to show you how in acute heart failure the fluid status balance is fundamental in order to start appropriate treatment. In fact, when the patient presents in the emergency room with acute heart failure from this big registry of more than 45,000 patients we published recently, if you are going to waste time and you are not going to make appropriate evaluation of the diagnosis and the fluid status, you are going tremendously negatively impacting both in acute mortality and hospital length of stay. The recent guidelines of the European Society of Cardiology focused a lot on the importance to understand immediately when we are dealing with a patient with acute heart failure to evaluate how much congestion is there, because you know that 95% of patients presenting with acute heart failure, congestion is there. But it's not only important to detect congestion. You really want to assess how much congestion is there, and you also to link congestion with flow. You want to understand, for instance, if the patient is cold dry, means low perfusion and a low circulating level of fluid, that's going to be with high mortality linked. So there are many tools that we can use to assess the fluid status in patients with acute heart failure. For sure, clinical judgment is always important. You can do chest X-ray, you can do also B-lines by ultrasound. The problem that the fluid is not only circulating fluid, so you want to really to assess total fluid content, intracellular, interstitial, to start the appropriate treatment. This is the issue. First of all, I think that the most important tool is to visit the patients. I think it's very important to be very accurate in analyze the clinical status of the patient, and you have a very, very good opportunity just to check the jugular distension or just the pitting edema or the third sound gallop to say, okay, this patient has a lot of fluid I need to remove. So clinical judgment, and for my opinion, is the most important tool that will be never replaced, although we have new technology. So what about chest X-ray? For sure, interstitial edema and fluid accumulation in the lung should be reflected by the evaluation of chest X-ray, which is the issue, that 25% of these patients can have a fluid accumulation that is not linked with this kind of a picture. So, I mean, you really cannot use only chest X-ray to have an idea how much interstitial fluid is in the lung. We have just recently, the Great Network, published this consensus position on the use of ultrasound, both echocardiographic assessment and vena cava assessment, in order to detect both intravascular content of the fluid. Let's say this is very low fluid content circulating, and you see an increase in vena cava that is reflecting the intra-circulating volume. And of course, also echocardiographic assessment is important because this is the size of left ventricle in case of patients with a low amount of fluid in left ventricle, and this is a dilatation of the heart that is linked with congestion. But I think I would like to stress a little bit more on the importance of to do now the chest analysis of ultrasound, that you're going to have interstitial evaluation by Comet's B lines, that at the moment the patient presents is even easier than doing the chest X-ray. So we used recently into the great network we published in European Heart Journal this data from using this bioimpedance vector analysis that I'm sure many nephrologists in the audience are familiar with because they use dialysis in order to monitoring the efficacy of removal of the fluid, and this is used to be sure that you are going to come from increasing fluid to normalization. And from our data again, these tools was working well because it's representing intravascular and interstitial intracellular fluid, especially when coupled with the clinical judgment. What is the problem? That this kind of technology is not going to give any kind of information about perfusion that from beginning I told is very important, and moreover is not evaluating the third space that is sometimes very important to remove in order to have the patients getting better outcome. So moreover, if you use this machine with another biomarkers that is a surrogate of intravascular circulation, like such BNP, you can have an additive value if the BNP is a gray zone and the BIVA is going to give you more information. But still, you are going to miss important information about the third space and perfusion. There are some promising biomarkers, such as bioadrenomedulin. We just are going to publish this data where it's very clear that bioadrenomedulin is a link to reflect the clinical judgment, and this increase if the patient has congestion. So in the future, probably this biomarker should be better than natriuretic peptides in detecting total body water content. But again, into the great network, we recently published this paper where it's clear that once you have a fluid accumulation, acute heart failure, you need to understand which patient is going to have a shock, and then you want immediately admit to ICU, or is not going to have a shock, and this is based on the evaluation of perfusion. So you need to know cardiac hemodynamics with the fluid accumulation, and you need a tool that is giving the same information. We had a paper recently that used Nexfin, was able the patients in acute heart failure to be detected for the occurrence of low flow. But the issue with this technology, again, that is probably not really reliable in the case of measuring cardiac output or total peripheral resistance in the course of patients with the shock because pressure is very low, or hypothermia, and moreover, it is not linked with any information about total fluid content status that as of the beginning and from the three previous speakers is ready to go as the decision-making for therapeutical strategy. Now we have a new device that is NICAS. This is a whole-body impedance cardiography that very simple, using 4 electrodes, you can give to the patients the current on the frequency of 1.4 milliamperes, and you are going to detect both the hemodynamics, cardiac output, stroke volume, and total peripheral resistance, and the total body fluid content that are linked with very good correlation with this Van Ganz evaluation. And so this is a device that is going to give you important information for fluid status and hemodynamics at the same time. So importantly, this machine is making stroke volume directly, so all the other are derivate parameters and also total water content. And I think these two are the most important data you want to have in order to start the treatment. You see that there is some difference between male and female in order to have normal body water content using this machine, but you know that if you are in these 2 red lines, you are in the normal range. If you are up, you are congestive. If you are down, you are hypohydrated. So in a few minutes, I'm going to show you our very preliminary data on a pilot study we just finished in acute heart failure patients arriving in the emergency room in order to compare the evaluation of this new technology that is going to provide the fluid status assessment and the monitoring compared to BNP, clinical judgment, bioimpedance spectral analysis, lung ultrasound, vena cava evaluation, and the NICAS. And we did this evaluation at time 0 AD arrival, 2 days and 3 days later, and discharge. So this is, again, a very preliminary study, just 40 patients. I just would like to tell you that now, in acute heart failure, we are dealing with very, very complex patients, very older, and moreover, they have basically many other diseases. And don't forget that in our experience, but in many experience, the kidney involved in these patients is very high. So you must really check also the kidney in these patients. What is important to note that using chest X-ray, you are missing again 25% of the patients because it was not reflecting the total interstitial congestion. And the same for B-line. So no one of these was going to detect 100% of the congestion. So we need something more. On the other side, again, the NICAS was very clear to show reduction of systolic functions and increase in total body water content that was important. What about the prognosis of these patients? What is interesting to see that, first of all, again, I will start from the beginning to tell you that clinical judgment at the moment you are going to decide to discharge the patient is very important. And in fact, if you are going to make again the physical examination and vital parameters, you can have a significant possibility from arrival to discharge to have good evaluation of to moving the overload fluid status in the body to normal fluid status. So again, clinical judgment is always important. But when we compared in order to see the outcome of these patients, both for mortality and rehospitalization, it's very clear that the stroke volume from NICAS and total body water were the best predictor of in-hospital mortality. So time zero and discharge were very important to understand which patients were going to die. And interestingly, never natriuretic peptide or BIVA have a predictive value for these patients. You know that for acute heart failure, rehospitalization is many issue. And again, if you are going to measure total peripheral resistance with NICAS at arrival and cardiac output, you can have important information which patient is going to be readmitted in the future, having also some cutoff you can use practically. Again, natriuretic peptide and bioimpedance vector analysis were not of utility. Let me just conclude my presentation that in patients with acute heart failure, fluid status assessment is very important. First of all, again, clinical judgment is crucial, but alone should be not enough. You can add some simply methods such as natriuretic peptides or lung ultrasound or vena cava evaluation that can give you information. But what is the issue? They are, again, not measuring the total body water content. Maximum, they can give you the information about intravascular circulation or intracellular, but not the third space. It is important. And also, you cannot put Swan-Ganz in all patients at arrival to understand how is the hemodynamics. So the best way tomorrow would be to have a tool that is going to give you from the beginning, before you make therapeutic decision or before you make disposition, to put together information about the total fluid content and hemodynamics, because it's going to give important prognostic value. This is really important. In acute phase, you not only are dealing with diagnosis, you are quite good in making diagnosis. You want to make prognostic information on these patients, and in hospital mortality and short-term admission were very, very well detected by NICAS. Of course, we need more data in a multicentric study to really confirm these preliminary results. And for this, I conclude my talk, and thank you very much for your attention.